Welcome to Unit 7, Part 1, Complex Neuro. So our content is going to be split across two different videos. The other video should already be posted. It is a shorter video. This will be the big chunk of what your exam is going to be, added with Unit 8, that's your burns and your shock. So we have to understand mobility, sensation, and cognition. How do our neurons respond to stimuli? Increased intracranial pressure, and what signs and symptoms we would look for. What caused that pressure to increase? Knowing what a cradiotomy is and our post-op findings or nursing interventions, inflammation of the brain, so your meningitis, your viral versus your bacterial, and then myasthenia gravis, Guillain-Barré, those are autoimmune issues, spinal cord injuries, and then our diagnostic tests and procedures. So we have chapters 35, 36, 37, 38. Remember, focus on the specific page numbers. So what are our diagnostic tests for neuro disorders? The big ones are going to be your CT MRI or MRI. That gives us a good visualization. If it's with contrast, we can actually see the blood flow going through the brain. Ultimately, if the patient's having an MRI, you have to instruct them that they have to lay really still. There are great machines now that do not require you to be in that long tube that makes you feel claustrophobic. Patients that are severely claustrophobic, we have noted to give them like a benzo to kind of relax them. However, keep in mind that those medications slow things down. Other things that we could do to kind of help them without medication is kind of like put a washcloth over their face so they don't see what's happening. Make sure that they're laying still. And then, of course, I hope that we have all known or even realized with recent news, I think it was in the last year, some gentleman went into an MRI machine with a necklace on, and he ultimately passed away because the metal clung to the machine and choked him. So ensure no metal on the patient prior to imaging. We can also do X-ray. X-ray is really going to tell us if there's like a skull fracture or if there's something else there. EEG is great to look at those brain waves to note that is the patient having a seizure, what's happening there, is the patient brain dead. Lumbar puncture, that is a great tool to use to identify looking at your CSF fluid, looking at the pressure, looking to see what's in the fluid itself. Cerebral angiography, looking at how the blood is moving through those arteries. We can do a PET scan, electromyography, your EEG again. Sorry, these are kind of all laying in together. Muscle and nerve biopsies to see if the nerves are synapsing to the muscles. That goes in with your EMG. Blood cultures, especially if we're suspecting meningitis, blood cultures are going to identify if it's bacterial versus viral. And if it's bacterial, we definitely need those cultures to let us know what antibiotic is probably going to be the best tool to use. We can look at evoked responses, but ultimately, let's say your patient is coming in through the ED and complaining of a severe headache. They walk themselves in. So you're already starting your neuro assessment. They're walking. What does their gait look like? Are they are they answering questions when you ask them? Are they taking some time when you ask them questions? Are they able to look at you? Are they following you around the room? Are they moving their extremities? Those are all a part of the neuro assessments that you can actually do before you even touch the patient. So get a baseline neuro assessment. Make sure you're monitoring that level of consciousness. Did they come in alert and oriented, and then within the last hour, they are going more lethargic? The Glasgow Coma Scale, it is warranted as soon as they walk through that door. we need that baseline Glasgow Coma Scale to let us know if the patient is improving or getting worse. Pupil assessment is one pupil big and one pupil pinpoint. We know something has happened. Are they both pupils blown? Are they on alcohol or some kind of opioid? If they are on cocaine, those are going to distinguish your pupil size. Can they tell you who they are, their date of birth, where they are, what brought them in? Posturing, remember your decorticate and your deceborate. And then we're going to talk about the doll's eyes on the next slide. From your book, there is a critical rescue and priority. So a decreased level of consciousness and orientation is the earliest and most reliable indication that central neurologic function has declined. Be alert to both sudden and subtle changes, particularly when changes are noted by family members or others that know that patient. If a decline in level of consciousness occurs, contact that rapid response team. I've always said that your loved ones are a good resource for you to utilize. Maybe they're calling their straw a spoon now. And their loved ones are in the room. They're able to connect those dots and let the nurse know. So always use your resources. So doll's eyes test. When you walk into that patient's room, you should already start your assessment without even touching that patient. You're walking in. Are their eyes fixated straight ahead? Or are they able to watch you by when they're not moving their body? Maybe they're in a cast, they had a head injury or spinal cord injury, and they've got a C-collar on. Are they able to wiggle their eyes or follow you around the room? If they have a fixed or absent reflex to be able to do that, that's a bad sign. So we want those eyeballs to be moving or following objects around the room. Here's an example of your EEG. We're looking at those brain waves. We put those electrodes, just like the electrodes pretty much that you use on your cardiac. They're just a little bit smaller, but we're going to put those all over the head, and it's going to monitor the waves that are occurring in the brain. An EMG is going to monitor your muscle and your neuron. Is your muscle able to respond to stimuli? And then, of course, your posturing, the decorticate. Those arms and hands are going into the core. The legs, the feet, they're turned into the core. That means that there is issues with the cervical spine or cerebral hemisphere. Where your deceborate, they're going out. They're positioned outwards. That means that there's probably a problem in the midbrain or brain stem or the pons. I've always said that this posturing is probably a little bit worse than this posturing. Now your pupils. Pupils are very important. They tell you a lot, especially when you're seeing a patient coming in through the ER. So are they both dilated or are they both pinpoint? That's when we can say, hey, have you used any substances lately? We know that if they're non-reactive, you shine that flashlight in their eye and they're not changing pupil size, that it could probably be a brainstem injury. However, if they are reactive, we shine that light in their eye, it's typically reversible. They're probably just drunk or on some kind of drug. Eyelid closure, diplopia, eyelid closure typically will cause that diplopia. It is something that has to do with the cranial nerve 3 that allows you to open up your eyelid. We can see unilaterally dilated. So if it's reactive, we have increased intracranial pressure and it's going up. One of the nerves is being pushed on. So you're going to have pupils that are unequal in size. Non-reactive means increased ICP. Non-reactive could also mean head injury as things progress and get worse. So just pupillary changes or eye signs different depending on which areas of the brain are damaged. Pinpoint and non-responsive pupils are indicative of brain stem dysfunction. The avoidant pupil is regarded as mid-stage between normal size and a dilated pupil. And we have asymmetric, which is one is dilated and one is constricted. Always think if you see this, there has been a head injury and they are having increased intracranial pressure. Now, it could be fixed. I did go to nursing school with somebody that had this, and she did have a TBI, and this is just how her pupils were. So your Glasgow Coma scale, we have to know the outcome that we get really worried about, so anything less than 8, and what we expect our patients to walk in that number. So mild, we want our patients to be about a 15 on any given day. However, that's not always the case in the hospital. So a mild Glasgow Coma scale could be a mild traumatic brain injury. Could be a concussion. Maybe they're playing sports and got hit in the head. They feel a little dazed and confused. They have a loss of consciousness for up to 30 minutes or a loss of memory before the event happened. But these symptoms are probably going to be reversed and, well, not reverse. They're still going to have some scar tissue there. We can always tell when somebody's had a concussion over and over and over again. If you ever watched the Aaron Hernandez documentary on Netflix, that is basically what happened to him. He had several concussions playing football, and they just kept adding up until his brain pretty much was scarred up all over. Now, if we have a mild concussion, they're still kind of responding to you. They might be a little bit confused, tired, but those symptoms are going to resolve hopefully within the next 3 days. Now, moderate Glasgow Coma scale, so your numbers 9 through 12, especially lasting a longer amount of time. They've had a loss of consciousness. This could be post-traumatic amnesia, and it could last for up to 24 hours. Now, your severe cases would be your scale of 3 to 8, greater than 6 hours, and a loss of consciousness. This is going to require critical care treatment. We have always said anything less than an 8 on your Glasgow Coma scale is very concerning. So this is just an example of our Glasgow Coma scale. You guys should be doing them on your clinical packets. So we're going to be looking at the eyes and the response to the eyes. Are they spontaneously open when you walk into the room, or do they only open to pain? So whatever, let's say your patient has eye opening when you talk to them, so they have a 3 there. Verbal response, are they oriented times 3 or 4? Or are they unable to actually talk to you? Let's say they just have a 4. They're confused. They're able to respond, but they have some confusion. So 3 plus 4 is 7. Now your motor response, are they able to move their arms up and down and their feet side to side? Are they obeying your commands? Or do they only move to localized pain? Do they have abnormal flexion when you touch their reflexes? Do they flex or withdraw from pain? Or do they have no response? Let's say, so they open their eyes to speech, they have some confusion, but they're able to obey commands. So we had a 7. 7 plus 6 is 13. So we can say we have a mild concussion or a mild Glasgow Coma scale. Now, key things to remember. Your patient came in, they are 13. They get sent up to maybe observation unit. If that nurse starts to see a decrease of 2 or more points in that scale from that baseline, that nurse better be calling a rapid response. They are deteriorating. How does this happen? Wow. So when you have a head injury, we have this thing called like a rebound effect or oxidative stress. So you've hit and damaged that vessel or neuron, and then the CO2, all of that stuff starts to get released to vasodilate and helps, it's trying to help bring in oxygenated blood to kind of repair things. However, when that happens and you vasodilate, things start to leak out, and that's going to damage the surrounding tissue. Doesn't happen in big amounts, hopefully. However, if it is a serious injury, you're going to have that initial injury, and then you could also have a secondary injury from that oxidative stress. More tissue is going to die off. So that's why we say a decrease of 2 or more points in your Glasgow Coma Scale means that there's more damage occurring, and it is not something to mess with. We can't come back from that. Your critical safety priority, critical rescue. So a decrease in 2 or more points in the Glasgow Coma Scale is clinically significant and should be communicated to the doctor immediately. Other findings requiring urgent communication with the primary healthcare provider include a new finding of abnormal flexion or extension, particularly the upper extremities, so your decorticate or deceborate posturing, pinpoint or dilated non-reactive pupils. So your pupils are either fixed and they're teeny tiny, or they're fixed and they're super dilated. Sudden, subtle changes in mental status. So maybe they're becoming more lethargic. Remember, a change in level of consciousness is the earliest sign of neurologic deterioration and should be treated as an emergency. Communicate early recognition of these changes to the rapid response team or the doctor to prevent further complications in CNS function. That's just another picture of our Glasgow Coma Scale. And this is our posturing. We have decorticate into the core and deceborate. It's going outward. What do we really get concerned about with deceborate posturing? Well, don't forget that deceborate could mean that there is a brainstem injury. And what is in our brainstem? We have our pons, our medulla. What do those centers regulate? Our breathing, our blood pressure, all of the stuff that's keeping us alive. So this is why I said before, you get really worried when you see this posturing, because that brainstem controls a lot of your breathing and your blood pressure, things that keep us alive. So a nurse asks a client to take a deep breath during an EEG or an EEG. The client asks, "Why are you asking me to do this?" How would the nurse respond? So take a deep breath during an EEG. Why are you asking me to do this? The answer is C. Hyperventilation causes cerebral vasoconstriction, and that is going to increase the likelihood of seizure activity. So the client's going to be asked to breathe deeply 20 times for 3 minutes. And that's going to hopefully stop extra brain activity, resulting in a seizure. Now your ICP, your normal pressures in your head should be anywhere from 10 to 15. That includes blood flow, vessels, your brain, and your CSF fluid. So there is limited space. We have a skull. The skull should not be moving. We only have so much room in our head to fit those things. So your brain, your CSF, your blood, all of that has just a limited amount of space. The leading cause of death from head trauma in clients who reach the hospital alive is your increased intracranial pressure. When it increases so much, your brain can herniate, or you get lack of blood flow, lack of nutrients and oxygen. If any of these increase in size, there's an increase in pressure. So if the brain swells, you're going to have less room for oxygenated blood or CSF fluid. If the tissues around the brain swells, again, there's going to be less area in certain parts of the brain, less area for blood flow. If there's too much CSF fluid, if the blood vessels are vasodilating, all of these can increase pressure. So remember, the skull is unable to expand, therefore any lesion or fluid will take up space and increase pressure. Swelling can occur by tissue injury, can occur through surgery, leakage of blood, tumors or abscesses. So tissue injury, maybe that patient got a contusion. Remember, we get that primary injury, and then we get that secondary oxidative stress injury. Surgery, anytime somebody has surgery, they're going to have inflammation. That can cause ICP. Leakage of blood, maybe there's an aneurysm and it ruptured. Any types of tumors or abscesses. I always like to talk on abscesses because when I went to pediatrics, it's like a whole different world when you go to peds. It's the same, but it's completely different. Little kids are very prone, or not very prone, but it can happen. I used to see it all the time. Sinus infections, if it's not treated appropriately, they get this thing called an empyema. And that empyema can build like a little sack of pus, and it can go anywhere in the body, but really think about where your sinuses are and think about what's closest to it. So they can get a nice little pus pocket in their brain. Is that going to have increased intracranial pressure? Absolutely. I always like to touch on that because children tend to not complain a lot, or if they do complain, especially nurses, I don't know why this is, but we tend to say, oh, go drink some water, you'll be fine. Don't do that. If they're complaining of a headache after they've had like an upper respiratory and they went to their sinuses, they were on antibiotics, maybe they took all of their antibiotics, but they still have that headache a month later, you need to go get it checked out. So as tissue swells, fluid increases, pressure is placed on the optic nerve, you'll have your pupils are going to then react slowly, so you'll see unequal size in pupils. You could see progression to both of them being dilated. They could be fixed. Then pupil size becomes fixed and reflexes disappear. Brain stem injuries or pressure on the brain can cause respiratory depression. It can cause heart rate, blood pressure, abnormal movements. All those can go out of whack if it's something with your brain stem. Hypoxia, and that's going to lead to tissue death throughout your brain and your body. CO2 is going to accumulate, causing vasodilation, and that's going to further increase intracranial pressure. That's that oxidative stress situation. If not fixed, the brain stem will herniate, and that will cause death. Now, when we say herniate, that means that all of the brain, or that brain stem, is being shifted into one section. It's being compressed now. There's no blood flow going through it. It is going to die. So if your brain stem is pretty much being herniated, that means it's almost like it's severed and it's not getting any oxygen to that tissue. So those neurons, that tissue is going to die off. What does that mean? You're going to have no respirations, no heart rate, no blood pressure. Causes of increased intracranial pressure. We all know what can cause traumatic brain injuries or injuries to the head. It could be a fall, it could be trauma, motor vehicle accident, head injuries from playing sports or falling off of something, some kind of trauma. So blood flow comes along to make the bruise, and that's going to take away blood cells as the bruises goes away. Think about a bruise on your arm or leg where you can see it. Eventually it's going to go away, but it'll get deeper in color and bigger before it gets better. You can also have ICP with disease or infection. So think about your meningitis. Inflammation, especially after some kind of surgery or trauma, and then hemorrhagic stroke. So you had an aneurysm or a severe escalation of blood pressure to the point that the vessel ruptures and then the blood starts to leak out into the tissue. So our assessment findings for increased ICP. We need to be looking for our Cushing's triad. So your systolic blood pressure goes up, your pulse goes down, your respirations go down. Now let's talk about initial findings. You're going to see just a decline in your patient, altered loss of consciousness, restlessness, headache, confusion. Now what does restlessness look like? It could just be, maybe they're not able to get up and walk around. It could just be them fidgeting nonstop, maybe moving their legs back and forth. It could be them picking up the bed sheets. That is going to be your initial sign that they have increased intracranial pressure. Now, after that, they're going to have vomiting. It's like the projectile vomiting. Projectile and reoccurrent. After that, you're going to see unequal pupils in an abnormal response. This is where those pupils start to dilate and maybe get fixed. So blown pupils, that is a late sign. If pupils are unequal and have slowed reactions to light, the patient is unable to follow directions. That is a decrease in your Glasgow Coma Scale. You need to call the doctor. If they have posturing, that's a sign. So decorticate or decelerate, it could be they're flaccid. Remember, your decelerate is brainstem. You look for your respirations, your blood pressure, heart rate. Decorticate, hopefully, decorticate posturing, I've always kind of correlated it with cerebral palsy. You can function if you've got this posturing, just depending on how severe it is. And then your Cushing's triad, that is your late sign. It's an emergency. So you're looking for bradycardia, raising blood pressure, especially your systolic, widening pulse pressure. What does widening pulse pressure mean? It means when you're looking at the blood pressure, let's say they were healthy, 120/80, but they came in because they had a head injury. Now we look at their blood pressure 2 hours later, and now it is 160/40. The systolic and the diastolic, you should not have more than 40 numbers there. That is when it starts to jump really big like that. That means that you're not perfusing the way that you should. So some books combine the rising blood pressure and widening pulse pressure and add slow respiratory rate as a third part of Cushing's triad. Just know systolic blood pressure jumps up, your diastolic starts to go down, your pulse is down, your respirations are down. This is pretty much everything I just said. So key features, you'll have those behavioral changes. Don't forget that restlessness as an early sign. They're picking at things. They could have a headache and projectile vomiting. Cushing's triad is your very late sign. They're going to be high risk for seizures as well, and then abnormal posturing as a late sign. Your critical safety rescue. Be alert for symptoms of increased ICP in a stroke patient and report any deterioration in the patient's neuro status to the doctor or the rapid response team immediately. The first sign of increased ICP is a declining level of consciousness. So increased pressure, just some regular signs and symptoms. Always remember your restlessness and these decreased LOC are your early signs. And then your late signs are going to be your posturing and your Cushing's triad. So how do we manage ICP or increased ICP? We're going to elevate the head of the bed by 30 degrees. If we lay that patient flat, gravity is not helping them at all. So elevate the head of the bed, keep them in a neutral position, avoid any flexion or extension of the neck. So make sure that that head is maintained at midline point in a neutral position. We do not want to agitate anything on that patient. When you're rolling your patient, you need to log roll the patient and avoid hip flexion. Any type of pressure on that spinal cord with the CSF fluid is going to increase the pressure in the head. So make sure you're not moving them, you're not flexing them. Our whole goal is to decrease the edema in the head. So some drugs that we can give. We can give a hypertonic solution or an osmotic diuretic called mannitol. Mannitol is going to help with the pressure in the brain, and hopefully they can diurese it out. We're going to monitor those eyes and nose to make sure that they're being diuresed appropriately, and they're going to be put on fluid restriction. We are not going to add more fluid until they have healed. The whole goal is to lower the cerebral spinal fluid. We can do a drain system, so an intraventricular drain system, a shunt. We can do a craniotomy sometimes, but your go-to is always going to be your mannitol and fluid restrictions, maintaining that patient in a neutral position with the head of the bed elevated. So we do want to maintain cerebral perfusion, so we're going to monitor our cardiac output, manage IV fluids carefully, and inotropes as needed. If it is meningitis or due to a bacterial infection, or maybe they got an infection from surgery, our goal is to control the fever with antipyretics and gently cool with a cooling blanket. We do not want our patient to shiver. Shivering equals agitation to the already increased pressure in their brain or their head. Oxygenate. So make sure your ABGs are in normal limits. If there is a lot of acid building up, we know that cellular death is occurring. Hemoglobin levels in hyperventilate to decrease CO2. Increased CO2 causes vasodilation, cellular death. Important to hyperoxygenate, not hyperventilate. Reduce cellular metabolic demands. We can give them barbiturates and sedation. So we want our patient to pretty much be in a sedated state to allow for proper healing. No stimuli. So low lights, quiet voices, nothing that is going to overstimulate them. Respiratory patterns are going to change with your brain injuries, and we need to be able to tell what kind of pattern it is. A lot of time it's going to be your Cheyne-Stokes. Monitor level of consciousness frequently if suspected epidural bleeding. So if we suspect that there is some bleeding occurring, it's going to be a neurosurgical emergency. Call the doctor. Our medication, so our mannitol, this is the drug of choice. It's your hypertonic solution. It's given through a filter to eliminate crystals. It's an osmotic diuretic that pulls fluid from the brain tissue. Now, furosemide can be used in adjunct to kind of help as that fluid gets pulled from the brain tissue, hopefully it goes systemic, and then we can give them furosemide to actually pee it all out. And it helps reduce that rebound edema. You must monitor your I's and O's every hour, as well as your kidney function. We also want to monitor our sodium level. Hypertonic solution, sodium level, very important. Just want to make sure I covered everything. So your mannitol is used to obtain serum osmolality of 310 to 320. You must monitor your electrolyte levels every 6 hours. Maintain strict measurements of your I's and O's, and check the patient's serum and urine osmolality daily, sodium blood levels at regular intervals. Because it is a hypertonic saline or hyperosmolar agent that's going to reduce and improve cerebral perfusion. Strictly from your book. Moving into your traumatic brain injuries. So what is a traumatic brain injury? It is a temporary or could lead to an permanent impairment in cognition, mobility, sensory perception, and psychosocial function. You can have a TBI and be completely fine, but you could also have a TBI and it could pull your life all apart. So just depending on where the injury is, how severe the injury was, in the treatment that was given. So mechanical force that is indirect or directly applied to the brain. So a direct injury would be that initial blow to the head. An indirect injury or that secondary injury is a rebound effect from that initial injury or a rebound effect from something else that has happened. I kind of think of your indirect injury as maybe whiplash. So you're in that motor vehicle accident, you get hit, maybe in the back of the, get hit in the back of the car by someone that's going like 60 miles per hour and you're at a stop sign. Your head is going to probably hit the steering wheel, and then it's going to go backwards, and the back of your head's going to hit the back of your seat. That's two injuries. You're going to have a direct injury when your head hits, but then that indirect injury is where your brain flips backwards, or your head goes backwards really quick, and you get whiplash. That's an indirect or a rebound injury. There are types of injuries. We can have shearing injury, so tearing of brain fiber or brain tissue, contusion, which is bruising, laceration, torn tissue, and then we have A-cell, D-cell injuries, and that is also what we call like whiplash. So acceleration, external force contacting the head and placing it in motion, and then your deceleration is moving the head so suddenly, and then it hits a stationary object. So cerebral spinal fluid is there to support the brain and protect it. However, when you have that direct blow to the head with a rebound, sometimes there's nothing that can really protect the brain in that situation. So a concussion, a mild traumatic brain injury, so your Glasgow Coma scale of 13 to 15, a contusion, blood that comes underneath the skin due to trauma that creates a bruise. Your coup contra coup, also called your acceleration deceleration. So contusion that presents at both sides of impact. Okay, so you're in your car, someone hits you in the back. Your head hits the steering wheel right here, or maybe the airbag gets activated and hits you in the head. Well, you get that whiplash where your like head whips backwards, and the brain can hit the back of your skull. It could also be part of the seat where it's hitting. So you get these two injuries. These two injuries. That's your coup contra coup. And then we always say diffuse injury means all over the head. And when I think of diffuse axonal injury, I think of shaken baby. It is everywhere inside that head. So the brain is shaken much more violently. It can happen with other things. We see a lot with our soldiers that are overseas with bombs and all of that yucky stuff. But honestly, I just kind of correlate it with a diffuse injury with shaken baby. So types of concussions, you have your direct impact, hit the head, your A-cell, D-cell, hit here and then here, or a blast injuries. That is direct blunt force trauma to one area. This is your coup contra coup, same thing with your A-cell, D-cells. All right, when assessing a client who's had a TBI, the nurse notes that the client is drowsy but easily aroused. What level of consciousness will the nurse document to describe the client's current level of consciousness? So, has a TBI. I mean, that's important to note, but that's how are they responding is really what we need to know. Drowsy, but easily aroused. Does that mean that they're alert? No, they're drowsy. Does that mean they're in a stupor? No, because they're easily aroused. Coma? No, because they're easily aroused. So that's going to be your lethargic. The, their level of consciousness is lethargic. Your TBIs, remember, you can be fine with a TBI, just making sure that your patient is getting treatment appropriately and timely. Remember, you get that other injury after that initial injury. So death usually occurs at 3 points: immediately with injury, or within 2 hours of injury, or it could be 3 weeks of injury. I put this lovely lady's picture here. I forget what she played on. It had Lindsay Lohan and they were twins. Anyway, she was also Liam Neeson's wife. So she was on a skiing trip. She hit her head pretty hard and she got a subdural hematoma. Well, the thing with subdural hematomas, they're sneaky like a snake. She went to the hospital, got checked out, everything was fine. A week later, she died. So that bleeding eventually caused damage, and then it continued, and then ICP, and then herniation is probably what happened. So you could die immediately with the injury, or it could be weeks later. That's why it's so important if you get a head injury to go get checked out. Brain injury depends on the force of the injury, the type of the injury, and the location. So intracerebral hemorrhage, epidural hematoma, or a subdural hematoma. Where is the bleeding happening? Is it with the meninges? Is it outside the dura mater? Where is it? That's going to play a big role in the type of TBI. Injuries to the brain due to some form of trauma. So motor vehicle accidents or car crashes and falls are the leading cause of head injuries. So car accidents and falls. Your greatest risk factor is being elderly. So older patients with comorbidities and having safety hazards are at greatest risk for falling. That's why we talk heavily in like fundamentals. What are we doing to our patient's home if we're going to be that community health nurse? We're making sure electrical cords are out of the way, that they don't have any rugs, that their pets are not kind of weaving in and out of their legs, because older people, they lose their sensation, they could have loss of eyesight, all kinds of things. Ultimately, they're not as strong and flexible as they once were, and they're going to be at high risk for a head injury. Alcohol is often involved in accidents, and other causes of head injuries are assaults, sports-related injuries, and wartime blast injuries. So categorizing your TBIs: direct blow to the head, indirect from brain being jarred against the anterior side of the skull, your coup contra coup, or your acceleration deceleration, your blunt force trauma versus your penetrating trauma. Is it open or closed? Do they have a gunshot wound to their head? That means that it's an open area. Bacteria can get in there. So the skull is fractured, or when it's pierced by a penetrating object, that's going to expose it to the environmental contaminants, and that's going to cause further damage. Closed injury, so the integrity of the skull is intact, but damage to the tissue has occurred. That's going to help with increasing intracranial pressure. Is it a focal injury or a diffuse injury? Focal means one part of the brain, where diffuse means that it's all over. Hemorrhagic versus non-hemorrhagic. Are they bleeding or are they not bleeding? And then primary versus secondary. So your primary TBI occurs at a time of injury and results from physical stress within the tissue caused by blunt force trauma. You can have that open TBI or a closed TBI. Open, think gunshot wound, stabbing, the skull is open. Closed, the skull is not open. The tissue is damaged. Both tissues are going to be damaged though. Skull fracture. So a break in the continuity of the skull or separation at a suture line. We can see signs and symptoms if there's a skull fracture. Your basilar skull fracture, potentially serious due to the proximity of the brainstem. Why is that important? What's the brainstem do? Regulate your respirations, your blood pressure, your heart rate. So if we have a basilar skull fracture, the likelihood of morbidity is high. Skull fractures, other signs and symptoms are going to be rhinorrhea, so leakage of CSF fluid from the nose, otorrhea, leakage of CSF fluid from the ear, and that is going to require us with any head injury to be looking for a halo sign. This is why it's great to have those white sheets in the hospital. Your book says something about putting a napkin up or some kind of gauze up to the patient's nose and ears. However, the white sheets are fantastic as well. If your patient is lying there and they're leaking, you're also going to see that halo sign. So it is, I call it like an egg, a fried egg looking thing, but it's a bullseye. So glucose is going to separate from the CSF fluid. So look for the yellow halo on the gauze. Periorbital ecchymosis. That's the raccoon eyes. So you'll have bruising around the eyes. Battle sign is the periocular ecchymosis. So you'll have bruising around the ear area or the mastoid bone. And then you can also see cranial nerve damage. So maybe they're not able to open and close their eyelids, or maybe they're not able to follow you around the room. Think about your cranial nerves and what they do. Secondary brain injury. Good old Aaron Hernandez. It's a very good documentary if you haven't watched it. I am a psych nurse that is heavily interested in neuro. So his documentary was fantastic to me. Really opened up a lot of people's eyes, thank goodness. And hopefully we're going to see a lot more changes in our sports playing. But I digress. Okay, so secondary brain injury. Any process that occurs after the initial injury. It could worsen or have negative influence on the outcomes. What does that mean? Well, Aaron Hernandez was a football player. Football players get hit a lot. Even though they wear the helmet, does not mean that they're fully protected. So multiple concussions, multiple contusions, you name it. Eventually, anytime you've got repeated offense with inflammation, that's going to lead to like scar tissue. That's the easiest way to put it. And that scar tissue is going to make your brain go from this to all shriveled up. There's no perfusion happening. Most secondary injuries are from a mild TBI or a concussion. For moderate to severe secondary injuries, you could see hypotension, so your mean arterial pressure starts to drop, hypoxia, you could see some ICP, you could see inability to breathe and regulate blood pressure. That is not going to be your concussion. That's going to be more of your severe head injury. Your patient could be asymptomatic and then later diagnosed with CTE, so your chronic traumatic encephalopathy. Now, this is why when people do scans and the doctor goes, "Oh, are you a sports player?" Because we can see the concussions that have occurred in the brain. They don't go away. That scar tissue stays. There's injury to the vasculature, there's cell death, and then it gets shriveled up. Now your concussion. Remember, your concussion is a mild injury. And your Glasgow Coma scale can be probably 13 to 15. They could have lethargy, they could have some confusion, but ultimately they most of the time are going to be being able to respond. Now, overview. It is violent jarring that results in diffuse or microscopic injury to the brain. some causes. Could be a fall, could be shaking someone, motor vehicle accident, playing sports, getting hit in the head. Ultimately, it causes temporary neurologic impairment, and it can have complete recovery in about 72 hours, hopefully. However, there is a thing called post-concussion syndrome, and that's going to last for a couple months. So you'll have more amnesia, disorientation, more headaches, more behavior and personality changes, more sleepiness, and double vision. This happens, I mean, it's not common, but it happens it's ongoing. So after that week of having that concussion, you should be generally healed. If you're having any of these signs and symptoms, you should probably go get checked out. Your Glasgow Coma scale for a concussion is typically 13 to 15. Now, what happens if they're at a 13 and 2 hours later, they're now at a 10? That means you have to call the doctor. Remember, any drop in 2 by 2 is concerning. You got to call the doctor. It is normal to have a headache. It's normal to be sleepy. It's normal to not remember things, having amnesia. We do not take ibuprofen for this. We take acetaminophen. You can have it every 4 hours. No NSAIDs. We want to take acetaminophen for the pain. Now, back in the day, we used to tell our patients you have to get up every 2 hours. That's not the case anymore. What we do is we make sure that patient can go home with somebody if they come into the emergency room, and they can monitor it. The whole goal is for that patient to rest. The loved one can gently wake them, say hi to them, have them respond to a question, and go back to sleep. But the whole goal is for that patient to rest. Decrease the stimulation. So keep the lights low, keep the volume low in the house. Make sure they're not taking any opioids or sedatives, because that's going to definitely decrease their Glasgow Coma scale. It's going to cause some problems. It's going to decrease blood flow, but also it's going to be concerning because they're not going to be as arousable, and no strenuous activity. They could have some vertigo, so they're going to be at risk for falls, so be aware of balance issues. Our diagnostics for concussions. We will have an MRI or CT. Remember, we're having that patient lay completely still and no metal whatsoever. Our assessments, normal findings or expected findings: headache, balance issues, loss of memory or amnesia, sensitivity to light and noise, being restless or irritable. If they start to drop their Glasgow Coma scale, maybe they're not responding as much, call the doctor. So for TBIs in general, this is going to be your halo sign. The first priority for your nursing care for TBIs is assess airway, breathing, and circulation. They're going to be on spinal precautions. You're going to need to be getting vital signs frequently, doing neuro assessments. You definitely need to get that baseline so we know if they're improving or getting worse. Prevent that secondary brain injury, and monitor for your halo sign. So your safety priority: check pupils of patients with a TBI for size and reaction to light, particularly if the patient is unable to follow directions. To assess changes in level of consciousness, document any changes in pupil size, shape, and reactivity, and notify the doctor or rapid response team, because this could indicate increased intracranial pressure. Another example of why nurses love those white sheets, because we can see the halo sign. So your nursing assessment continued. If you can, always ask how the injury occurred and when. When did it happen and how it occurred. Our priority is going to be your ABCs. So airway, breathing, circulation. You're going to monitor for respiratory problems, diaphragmatic breathing or retractions, and diminished absent reflexes in the area. That typically means that there is a brainstem injury and things are going south really fast. Vital sign changes. So if your systolic blood pressure is going up and your diastolic's dropping and the heart rate's dropping and the respirations are dropping, that's your Cushing's triad, that's going to be an indication that there's increased intracranial pressure. So notify the doctor. Bradycardia, hypertension, decreased respirations. Safety priority, critical rescue. The upper cervical spine nerves innervate the diaphragm to control breathing. Monitor all TBI patients for respiratory problems and diaphragmatic breathing, as well as diminished or absent reflexes in the airway. So they no longer have a gag reflex. Hypoxia and hypercapnia are best detected through arterial oxygen levels, partial pressure of arterial oxygen, PaO2, your oxygen saturation, and end tidal volume CO2. Is there chest wall movement, and listen to breath sounds. Provide respiratory support, including oxygen therapy and bed positioning. How are we putting our patient in the bed? 30 degrees, head midline, minimal movement, minimal stimulation. Report any sign of respiratory problems immediately. Our second action alert. So position the patient with a TBI to avoid extreme flexion or extension of the neck. Maintain the head midline in a neutral position. Log roll the patient during turning to avoid hip flexion. And keep the head of the bed elevated 30 degrees. Generally, head of the bed elevation in patients with TBI is 30 to 40 degrees to prevent aspiration. However, increased head elevation significantly lowers systemic blood pressure. The patient does not benefit from drainage of venous blood or CSF out of the skull from this position. If hypotension accompanies an elevated backrest position, the patient may be harmed, so avoid sudden vertical changes. And of course, your nursing diagnoses. The biggest thing we're looking at is your Cushing's triad, so making sure that they're being perfused, that they're breathing, that they monitoring your level of consciousness. And our goal is to keep the airway open, adequate perfusion, cranial perfusion, fluid and electrolyte balance. So if they're on mannitol, we're monitoring that sodium level, adequate nutrition, normal body temperature, skin integrity, helping prevent secondary injury, sleep deprivation, supporting the family, going to rehab. If you guys don't know about the rehabs in Florida for neuro spine injuries, a great one would be Brooks Rehab up in Jacksonville. And our whole goal is to prevent further complications. A nurse assesses a client with an injury to the medulla. Which clinical manifestations would the nurse expect to find? Select all that apply. So medulla is near your brainstem in the back of the head. So you could have decreased respiratory rate, impaired gag reflex, so impaired swallowing. Not really visual changes, that's your occipital lobe. Inability to shrug shoulders, absolutely. And loss of gag reflex. So A, B, D, and E. Now a craniotomy. What is a craniotomy? So incision into the cranium due to removal of a tumor or debulk or have a biopsy. We don't do it, but we are there for pre-op and post-op care. So it is done local or general anesthesia. You're going to have several burr holes drilled into the skull by a saw to remove bone to expose the area that is needed to get to. This is called a bone flap. The bone flap is then screwed and bolted back in with a drain, and we're going to monitor what is inserted. We'll have a dressing cap used to keep the area clean and dry, prevent the patient from touching it. Post-op concern is related to inflammation, swelling, and mental status changes, so increased ICP. Removal of the tumors is going to occur, but they're not always going to be able to get everything, not all the time. So they're going to do as much as possible without damaging other tissues, surrounding tissues. So we see here, this would be an open injury. Definitely will need some help there. Okay, so action alert. Assess neurologic and vital signs every 15 to 30 minutes post-op for the first 4 to 6 hours after a craniotomy. Neurologic vital signs. So that's going to be, can you tell your name, your date of birth, where you are, how you got here? Can you follow me around the room? Can you do your Perla stuff? And then you're going to do your heart rate, your blood pressure, your respirations, all of that every 15 to 30 minutes. So would this patient be on a med-surg floor? No, going to be in the ICU. If the patient is stable for 24 hours, the frequencies of these checks may be decreased every 2 to 4 hours. This is really important. So assess neuro and vital signs every 15 minutes for the first 4 to 6 hours. If they're stable for 24 hours, then it's going to be decreased every 2 to 4 hours. What are we going to report? Neuro deficits. A decrease in your Glasgow Coma Scale by 2. Loss of consciousness, motor weakness or paralysis, aphasia, decreased sensory perception, sluggish pupils, your PERLA, your neuro status. Personality changes as agitation, aggression, or passivity are also indicate worsening neuro status. So post-op care, neuro assessment, vital signs every 15 for the first 6 hours. Stable for 24, then you can decrease it every 2 to 4 hours. Report any neuro deficits and a decrease in those sensory perception. Decreased environmental stimuli, and do not cluster your care. This is important. Do not cluster that patient's care. Why? Because you're going to overstimulate them. Not only that, but you got to be in there every 15 minutes anyway. So do one thing, let them rest, come back in 15 minutes. Head of the bed at 30 degrees. Avoid extreme hip or neck flexion. Maintain that head at midline in a neutral position to prevent increased intracranial pressure. Your eyes and nose. Monitor for drainage. Report drainage greater than 50 mLs in 8 hours. No straining. So that means no bending over, no coughing, having that patient at midline position. You're going to have them on a laxative or a stool softener, probably. No straining, no coughing. And make sure you're monitoring that drainage. 50 mLs at 50 mLs for 8 hours. Bad news. So your craniotomy complications. They had surgery. The neurosurgeon was messing with all those tissues. What are they going to have? They could get infection. They could have inflammation. So cerebral edema. They can have a bleed, hematoma, hydrocephalus, meningitis. So the meninges are inflamed. So what are we monitoring for with meningitis? Nuchal rigidity, fever, headache, photophobia. CSF leaking. What do we look for CSF? Are they having fluid leaking from their nose or their ears? And what does that fluid look like when we put a piece of gauze, or if it's leaking onto their beds or white sheets? It's going to look like a halo. Seizures, fluid electrolyte imbalances, and respiratory issues. So after a craniotomy, monitor the patient's dressing for excessive amounts of drainage. Report a saturated head dressing or drainage greater than 50 mLs in 8 hours or every 8 hours immediately to the surgeon. You're going to monitor for ICP frequently. With any brain injury, you must tell the patient to go to the ER if they start having a worsening headache, seizures, persistent or severe nausea, vomiting, blurred vision, clear drainage from the ear or the nose, increased weakness, slurred speech, progressive sleepiness, unequal pupils. So you have a client admitted to the ED with probable traumatic brain injury. Which assessment finding would be priority for the nurse to report to the healthcare provider? A mild temporal headache, pupils equal and react to light. That's good. That's a good sign. Alert and oriented ×3. That's a good sign. And decreasing level of consciousness. So they had a probable TBI. And what is our priority patient? Anyone that has a decreasing level of consciousness. A nurse assesses a client who notes the client's position as indicated in this picture. How would the nurse document its finding? So you see the arms are shaped like a C. It's going into the core. So it is decorticate posturing. Meningitis. So if we break that word down, your meninges are inflamed, your neurons. So inflammation of the meninges, the pia mater and the arachnoid matter. If we look at this picture, your meningocele are right here. If they are inflamed, it's going to be pushing on the brain. So they'll have increased intracranial pressure. Increased ICP results from a blockage of CSF flow, the cerebral fluid, or a clot. It could be the blood flow. It doesn't matter. So the inflammation from the meninges is going to cause increased pressure in the cranium. So if the whole goal is to treat it quickly, and we have to decide, we have to figure out if it is viral or bacterial. If we do not treat it appropriately and quickly, it's going to become critical and it's going to lead to death, unfortunately. So prognosis is poor for the elderly and for the infants. Don't forget, the meninges are a protective membrane that surround the brain tissue and the spinal cord, your meninges. Likely culprits are going to be strep, meningococci, streptococci, and pneumococci. Bacterial is the most deadly. Bacterial meningitis is the most deadly. Bacteria reaches meninges through blood or infection in the ear or in the sinuses, and then is going to spread to the spinal nerves, the cranium, and then through that protective layer, the meninges. Causes neurodeterioration, hearing loss, losses of limbs. It could increase intracranial pressure, decrease blood flow, all kinds of awful stuff. Viral meningitis, typically caused by herpes, mumps, or enterovirus. Viruses cause cerebral vasculitis, which leads to the cerebral edema. It's irreversible when it gets to that stage, and there's going to be obviously neuro changes. Who is our biggest risk factor? It's going to be your college age students, so end of high school through college age. People ages 16 to 21 have the highest rates of infection from life-threatening Neisseria meningitis meningococcal infection. The Centers for Disease Control and Prevention recommends initial vaccine at the ages of 11 and 12. So around middle school time, most children will be getting that meningitis vaccine. And then again, a booster at 16, because the highest risk factor are people ages 16 to 21. And that's because they're constantly sharing things, doing naughty things. When they get to that college and they're free from their parents, they're doing all kinds of stuff that they probably shouldn't be doing. So adults are advised to get an initial booster vaccine if they're living in a shared residence, so college residence hall, military barracks, group homes, or traveling or residing in countries which the disease is common. They should also get vaccinated if they're immunocompromised, or if they don't have a spleen, because that makes them immunocompromised. If the patient's baseline vaccination status is unclear, we can still vaccinate them. The CDC recommends vaccination. It is safe to receive a booster as early as 8 weeks after that initial vaccination. So your action alert that came from the book, the biggest things that you want to know are people ages 16 to 21 are high risk, as well as the elderly. Anybody living in shared dormitories or close living encounters. And when you do vaccinate, initial vaccine in middle school, ages 11 and 12, and then they get another booster at 16. So bacterial infection, group B strep, E. coli, we could do listeria, it could also be pneumococci, H. influenza, Neisseria, meningitis, but it can also be viral, and your viral is going to likely be herpes. Herpes is the biggest culprit. And don't forget, bacterial meningitis, it equals deadly. So our assessments, what are we going to be looking for? Fever, chill. Yes, we commonly associate nuchal rigidity, or the neck being very stiff and in a lot of pain, but we're not going to always associate that with meningitis. It is a common finding, but it's not always. Instead, we're going to look for fever, chills, Kernig's sign, and Brudzinski sign. So Kernig's flexing of the thigh at the hip and the knees at a 90-degree angle, and that's going to cause lots of pain or lots of resistance and pain, and that equals a positive meningitis finding. Brudzinski's is involuntary flexion of the knees when the neck is flexed. There's a picture on the next slide I'll show you. And the patient with both of these are going to be laying flat. We can also assess for level of consciousness changes, photophobia, so being sensitive to light, severe headaches, nausea, vomiting. If it is bacterial, you're going to assess the eye, pupil shape, and reaction. They could have a petechial rash. That is typically with your severe meningitis. So your Kernig's, you flex the hip and the knee, and there's going to be more pressure. Now if you flex the neck and the knees, and there's pain and pressure there, that's a positive sign. So again, fever, chills, Kernig's, Brudzinski's, photophobia, bacterial is going to be assess your eyes. So how do we diagnose it? Lumbar puncture is one of the best ways to diagnose this. We can send off our CSF. We can look for bacteria. So if it's bacterial, the CSF is going to be cloudy. They're going to have increased pressures, decreased glucose, increased proteins, because bacteria has proteins. White blood cell, red blood cell counts are increased. And of course, we have to do a culture and sensitivity to figure out what bacteria it is. With your viral, your culture is going to be negative, and there's only going to be white blood cells that are elevated. So if we look down at this chart from your book, bacteria, the appearance is cloudy and turbid, the pressures are elevated, white blood cell counts are elevated, proteins are elevated, glucose is low. Viral, appearance does not change in the CSF fluid. It's normal pressures. The only thing you will see is elevated white blood cells. So bacteria has a lot going on, where viral just has the white blood cells. Question: a nurse prepares a client for a lumbar puncture. Which assessment finding would alert the nurse to contact the PCP? Shingles infection in the client's back, client is claustrophobic, absence of IV access, proximal nocturnal dyspnea. So we have a lumbar puncture, and we're assessing the patient, and what one would be a big concern. So we're sticking a needle through that patient's back. If they have an active infection on that back, then we are not sticking a needle through it. Claustrophobia, not really necessary for your lumbar puncture. Absence of IV access, that's typically peripheral central, that's not in the back. And getting short of breath when you're sleeping at night, not really related to the puncture. So no infection, no current infections when getting an LP. A nurse assesses a patient who is recovering from lumbar puncture. Which complication of this procedure would alert the nurse to urgently contact the doctor? Weak pedal pulses, nausea, vomiting, increased thirst, hives on the chest. So our focus is this lumbar puncture and a complication of it. So if we have a lumbar puncture, what are some complications? We can introduce bacteria to that area. We can cause some inflammation, and all of those are going to increase the chance of increased intracranial pressure equaling nausea, vomiting. Other things you would look for: severe headache, photophobia, level of conscious changes. Those are all signs of increased intracranial pressure. So medical management of your meningitis. If it's bacterial, we're treating with antibiotics. You're going to start that patient on IV antibiotics for 2 weeks, and then they're going to do PO or oral antibiotics for up to 8 weeks. The whole goal is to make sure that to decrease their intracranial pressures, so they're likely going to be put on mannitol. Steroids for inflammation, prevent seizures, so decrease stimulation, monitor sodium levels, monitor inflammatory levels, make sure that you're doing culture and sensitivities, and then monitor your neuro status. Your action alerts for your meningitis. For the patient with meningitis, assess neural status with vital signs at least every 2 to 4 hours or more often as indicated. The priority is to monitor for early neurologic changes that may indicate increased intracranial pressure, such as a change in your LOC, having seizures, and then your Glasgow Coma scale is really important to monitor. Remember, a decrease by 2, a change in 2 is bad. Place the patient with bacterial meningitis that is transmitted by droplets on droplet precautions, in addition to standard precaution. When possible, place the patient in a private room. Stay at least 3 feet from the patient unless wearing a mask. Patients who are transported outside of the room should wear a mask. Teach visitors about the need for these precautions. So bacterial meningitis needs to be on droplet precaution. The most important nursing interventions for our clients with meningitis are accurately monitoring and documenting their neural status every 2 to 4 hours. So pupil assessments, neurochecks, pulses, assessing their ABCs. They could likely need to be intubated and sedated. Temp monitoring, seizure precautions. They could go on anticonvulsants, eyes and nose, especially if they're going on mannitol. Bacterial meningitis requires droplet precautions. They are also on seizure precautions. The nurse is teaching a group of college students about the importance of preventing meningitis. Which health promotion activity is the most appropriate for preventing the disease? Eating a well-balanced diet that just keeps you healthy. It's not specific to meningitis. Having an annual physical exam, that's important, but not directly linked to meningitis. Obtaining a recommended meningitis vaccine and boosters. Or identifying signs and symptoms for early treatment. So we're doing health promotion. This D would not be correct, so it's C. Recommend meningitis vaccine by the age of 11 or 12, and then the booster at 16. Moving into spinal cord injuries. So causes of a spinal cord injury: trauma, violence, falls, tumors, cervical spondylosis, herniated discs. There's a lot that can cause cervical cord injury, and if you're not watching the Clancy trial, just jump on it. She had a spinal cord injury. It's very fascinating, the events that led up to things. I won't put my opinion on here, but it'll correlate with what we're learning. So types of spinal cord injuries. Potential survivors of acute SCI experience injury below the third cervical level. So what does that mean? Anything C3 and above equals death. Why? Think about where your spine is. So C4 injury. What is in the back of the head right there? Well, you've got your C3, but you also have your brainstem. Can we live with our brainstem being not functioning? No, because what's our brainstem do, or specifically our pons and our medulla? They regulate our breathing, our heart rate, our blood pressure. Incomplete partial spinal cord injuries, able to convey some messages to or from the brain, retain some sensation, possibly some motor function below the affected area, and is more common. And then a complete injury is a complete loss of motor function. So let's say we have a T6 injury. That means that that patient is paraplegic. They have use of their arms and their trunk area. It's just the lower body that they have lost function to. But that does not mean they could have a partial injury. So they could have some sensation in maybe this leg, maybe this foot. It's just the neurons are not synapsing at full capacity, so they may not be in total control of their movements or sensation. When we get a cervical injury, remember, we always really get concerned about a C5 and above, but C3 is likely not going to survive. C4, we really worry about it, and that's going to be a tetraplegic or quadriplegic. Quadriplegic means all four extremities, where paraplegic means the two. So paralysis below the level of injury. Injuries above C4 equals paralysis of the respiratory muscles in all four extremities. So quadriplegic. Higher the injury, the greater loss of function. Temperature regulation problems are going to be below the level of injury. So let's take their spine. Anything below here is going to have dysregulation of their temps. So nursing medical care. Our biggest thing is airway, breathing, circulation. No matter what it is, our goal is to make sure that patient has a patent airway, they're able to breathe, and they're perfusing to keep their organs alive. So they could possibly need to be mechanically ventilated. We're monitoring those ABGs, making sure they're not getting acidotic, or maybe if the vent's doing too much work, alkalosis. Vasoactive meds to maintain the blood pressure, and monitor for sensory perception. So get a baseline and then notify the doctor if that baseline decreases. So let's say they could feel their fingers and they could kind of move them a little bit, but the next day they're unable to move their fingers and they no longer have sensation in their fingers. That means that there is further damage occurring and you need to call the doctor. Make sure that they're getting steroids to decrease edema in the spinal cord, prevent secondary complications. So bed rest, No flexion of the neck, thoracic, or lumbar areas. Keep the spine straight. Do not flex it. Make sure that they are wearing a C-collar. They are not, you as a nurse and they as a patient should not take that collar off unless a doctor says so. You are going to log roll them. Remember, we have to keep the spine straight and with least stimulation. Halo traction, not to be confused with your halo that occurs with increased intracranial pressure. This is actually a traction device to keep the spine in a straight line from not moving. So we need to teach the patient, never move or turn the patient by holding on or pulling on this halo traction. I'll show you a picture in a minute. Monitor your neuro status, check the skin, wear loose clothing, assess for infection. They're going to have pin sites. I'll show you in a second. You're assessing the skin around the pin sites. And they must always have the wrench and key on the vest because you cannot do CPR through this traction. So it needs to be readily available. You are not taking it off unless it's ordered. It is there to keep the patient's spine in place, but if they are actively coding, you need to take it off. And prevent complications by positioning. So here is your halo fiction device. You cannot do CPR through this. However, you need the wrench and key so that you can take it off. You are going to be assessing these areas here that it's not screwed into their head, but it is holding it in place. So the skin can break down there. You have to monitor that skin. Now your complications of spinal cord injuries. Quadriplegia, also called tetraplegia, is paralysis of all four extremities. Quadriparesis is a weakness affecting all four limbs. Paraplegia, paralysis involving only the lower extremities. Paraparesis is weakness of the lower extremities. So weakness versus paralysis. So cervical injury will be tetraplegic or quadriplegic. Thoracic injury, more than likely going to be paraplegic. Lumbar sacral injuries will also be paraplegia. Wherever the injury has occurred, the loss is going to be below it. So if they get an injury in the mid-back, they're going to lose function in their lower half of their body. So below the level of injury, function's lost. They are going to lose voluntary movement, sensation, so pain, temperature, pressure, proprioception, so having like senses to what's close to them, bowel and bladder function, spinal and autonomic reflexes are going to be gone or not working as well. Injury above C4 could be fatal. C3 definitely fatal. So C3 through 5, concerns for respiratory. So the innervate phrenic nerve that controls the diaphragm is no longer working. Why do we need our diaphragm? It helps pushes the lungs up and down, allows them to also expand. That's no longer working. So respirations are going to be gone. Cervical spine injury, always make sure you're doing a respiratory assessment and maintaining the airway. Injury to C7, so further down on the cervical area, they can likely move their shoulders at this point. They may have some function in their elbows and wrists. They just might not have full function. So C7, some function of the shoulders and arms. Now a primary spinal cord injury. The causes hyperflexion, hyperextension, could be axial, excessive rotation, or penetrating trauma. What was the initial injury? What happened? So hyperflexion. It is sudden forceful acceleration of the head forward, resulting in extreme flexion of the neck. I'll show you in a minute. This is typically seen in motor vehicle accidents. Hyperextension, sudden acceleration, then deceleration, the coup contra coup, that is going to tear ligaments, fracture vertebrae, and rupture disc. Motor vehicle accident, being struck from behind. Or it could be a patient falls, let's say off the curb, and lands on their chin, so their neck gets forced back abruptly. Axial, vertical compression, which shatters the vertebrae. It could be from diving, falling on the butt, fall and landing on the feet, so like a crushing injury. Excessive rotation, turning the head beyond normal range, and then penetrating trauma, so a bullet wound or knife. So this is your hyperflexion. We see that there was an injury there. This is your hyperextension. Your compression injury, your axial. Right, now your secondary spinal cord injury is the result from worsening of the primary injury. So what happened that caused further damage after that primary injury? Hemorrhage, ischemia, hypovolemia, impaired tissue perfusion from neurogenic shock, and local edema. So, hemorrhage may manifest with a contusion or petechial lining into the gray or white matter, can result in shock and decreased perfusion to the spinal cord, or ischemia, lack of oxygen because of reduced or absent blood flow. Hypovolemia, we have decreased circulating blood volume. Impaired tissue perfusion from neurogenic shock. This is a medical emergency. We're going to talk about shock in Unit 8. Local edema. When we have lots of edema, decreases perfusion. Capillary compression or cord ischemia. Neurogenic shock. Vessels are going to dilate. They're going to lose their tone. You're not perfusing as well. Now, neurogenic shock can be confused with spinal shock. There are some differences. So shock associated with acute injury to the spinal cord. This is called vasogenic shock. Neurogenic shock and spinal shock, ways that we can differentiate. Spinal shock occurs immediately with the spinal cord injury. So immediate temporary loss of motor, sensory, reflex, and autonomic function. Immediate loss of sympathetic cord function below the point of injury. Blood flow to the spinal column is affected by that injury, so blood vessels are going to vasodilate, open up wide, blood pressure falls, and that equals hypovolemia. And what is shock? Low blood pressure, high heart rate. So duration can last less than 48 hours, but can continue for weeks after the body adjusts. Spinal shock is initial shock. It occurs immediately with that spinal cord injury. We call it vasogenic. If we break that word down, your vessels are the origin. You have blood pressure falling, they're dilating, and that equals hypovolemia. So your characteristics that you would be looking for. Paralysis, of course. Hypothermia. This sounds, if you're watching the Clancy trial, hypothermia. Wasn't her body at 82 degrees? No perspiration below the level of injury, temperature impairment, respiratory failure with cervical or upper thoracic injury. So always remember, above C5, we really start to worry about respiratory. Hypotension, bradycardia, bowel and bladder distension. They will have pale or gray skinned, or it could be flushed. You're going to call the doctor and the rapid response team with these characteristics. So a hypotensive patient with a systolic blood pressure less than 90. A MAP less than 65. Decreased level of consciousness. Symptomatic bradycardia means that they're kind of short of breath, they're lethargic, they're going cyanotic. SpO2, oxygen saturation at 95% or less. Decreased urine output because they're hypovolemic, the body's holding on to the urine. They're not perfusing, so the kidneys are actually being injured. So what do? Our nursing priority: assess breath sounds every 2 hours, every 2 to 4 hours for the first few days. Document and report any adventitious or diminished sounds. Monitor vital signs with pulse ox. Watch for changes in the respiratory pattern or airway. Remember that primary injury you could end up with a secondary injury, and it can go higher up the spinal cord. Intervene per agency or a healthcare provider when there's a decrease in saturation below 95%. So spinal shock immediately after the spinal cord injury. The vessels are vasodilating, their blood pressure is dropping, their heart rate is dropping, so they're hypotensive, bradycardic, they are hypothermic. They are no longer thinking, so decreased level of consciousness, symptomatic bradycardia. Their SpO2 is less than 95% because they're not perfusing. They don't have a good respiratory rate. MAP is less than 65, and they're no longer peeing. So diagnostic and treatment. MRI or CT to determine level of injury. Cord edema is going to peak between 2 to 3 days normally. It's not going to subside though. It's going to peak, and then it takes about a good week for everything to start to see some kind of like improvement. Not necessarily total improvement though. Why do we worry about the edema? Because it's going to be decreased perfusion. So what do we have to make sure that they're on? Some steroids. We can do a CT, MRI to determine the level of injury, spasticity or hyperreflexia signals, the end of spinal shock. So if they start twitching, you see some involuntary muscle movement, that's a good sign that the edema is now no longer. Medications: dextran, atropine, dopamine. Why are we giving that? Think about what they do. They speed up the heart rate. They help with perfusion. Now, neurogenic shock, we will touch more on this in Unit 8, but it is not immediate with a spinal cord injury. It occurs within 24 hours, but not immediately with the injury. Most common in a patient with a thoracic injury or above, so T6 and above. It is life-threatening. Disruption in communication between the upper motor neurons and the lower motor neurons. So spinal shock is temporary loss of spinal cord function after an injury, affects the spinal cord. We're neurogenic. Remember, anytime something is genic, that's where it comes from. So spinal shock is vasogenic, where neurogenic shock is neurons. So it's a type of distributive shock caused by loss of sympathetic tone, and there's damage to the autonomic nervous system. So it affects the nervous system. So spinal shock immediate with the injury is vasodilation. It is vasogenic. Neurogenic is permanent, happens 24 hours after the injury. It is nervous system in origin. So the upper and lower parts of your nervous system are no longer communicating. Your nursing priority: monitor the patient with acute spinal cord injury at least hourly for indications of neurogenic shock. We're looking for temperature dysregulation. We're looking at skin. They could have flushed skin or it could be gray and pale. Symptomatic bradycardia, level of consciousness, decreased urine output, hypotension, specifically your systolic blood pressure less than 90 and a MAP less than 65. You're going to be calling the doctor with any of those. And then do not forget the oxygen saturation less than 95%. We went over all of this. This is a good video just to watch on autonomic dysreflexia. So what is autonomic dysreflexia? It is an emergency situation. Uh, it occurs suddenly at any time after spinal shock subsides. So after spinal shock subsides, remember spinal shock happens immediately and then it'll subside within that week. So after that subsides, then they're at risk for autonomic dysreflexia. A massive uninhibited reflex of the sympathetic neurons are being discharged. It is an exaggerated sympathetic response, especially those that have an injury above T6, so the thoracic injury. So if you have high thoracic injury or cervical injury, you're more at risk for having this. The client's body cannot counteract the sympathetic response. So what is a sympathetic response? It's like your fight or flight response. Causes GI and GU, vascular stimulation. So how does this happen? The patient that had spinal shocks, it subsides 7 days later. Now let's say they're constipated or they're not having bowel movements or they're unable to urinate. They have a neurogenic bladder now, or something is happening in their GI/GU where they're not getting it out. So bowel or bladder distension or impaction, a paralytic ileus, UTI, scrotal compression, skin breakdown, hemorrhoids, anything in that area is going to overstimulate the sympathetic nervous system. Your characteristics of this: severe hypertension, remember your fight or flight response, concern. Now, if your blood pressure increases tremendously within a short amount of time, they could have a hemorrhagic stroke. You're going to see bradycardia. If the injury in the cervical area, respiratory failure. The diaphragm is going to be paralyzed. Numbness, paralysis. If the cord is completely severed, there's going to be permanent paralysis. So T6, autonomic dysreflexia, anything that is agitating the bowel or bladder. It could even be a crumpled up sheet in that area. It's just overstimulating those sympathetic neurons, causing severe hypertension, a drop in the heart rate, and a drop in your respirations. So key features: sudden significant rise in systolic and diastolic blood pressure, accompanied by bradycardia, profuse sweating above the level of the lesion. So you'll see them sweating in the face, the neck, the shoulders, because remember, it's above T6. Goosebumps above or possibly below the lesion, flushing of the skin, blurred vision, spots in the visual field, nasal congestion. They are your fight or flight response, vasoconstricted in their body, but your lungs and your face, vasodilation. And then the feeling of apprehension, throbbing headache. So how do we care for this? It is an emergency. So immediately elevate the head of the bed in a high Fowler's position. It lowers blood pressure through blood pooling in the lower extremities. Check for urinary or GI retention or impaction. Look at the sheets. Are they crumpled? Call rapid response. Call the doctor, but you have to stay with the patient. Look for the cause. So is their Foley catheter obstructed? Is it kinked up? Do they have a UTI? Do they have a wound forming? You may need to give them medications to lower the blood pressure. So if the patient experiences autonomic dysreflexia, raise the head of the bed to reduce the blood pressure, call a rapid, give them medication to lower their blood pressure, and determine the cause. I think we went over all of this. So if it's a UTI, we can look for stones, fecal impaction, irritation in the rectum, look for worsening pressure injury symptoms, monitor the blood pressure 10 to 15 minutes, and give nifedipine or a nitrate to lower that blood pressure. So your medications for your autonomic dysreflexia. Decrease inflammation. We could give corticosteroids. Prevent hypotension, dextran. So maybe we overtreated them with the nifedipine. So now we want to bring them back up. Treat hypotension if not prevented with dopamine again, if we gave them too much. Prevent bradycardia. So they have hypertension, they have bradycardia. We're going to give atropine to increase their heart rate. Reduce pain, opioids. The opioids will also help reduce their blood pressure and reduce spasms. So you can give them like baclofen, skeletal muscle relaxant. Assessment of your spinal cord injuries. Initial assessment is always your ABCs. So assess your breathing 2 to 4 hours during the first few days after a spinal cord injury and report any diminished or adventitious sounds. Report oxygen saturations less than 95%. And of course, you're going to be monitoring your heart rate, blood pressure, and perfusion. Glasgow Coma Scale, assess your level of consciousness. Get a baseline. If you see it start to drop more than 2, you're calling the doctor. Spinal shock occurs immediately with injury. Sensory perception and mobility. Injuries to the thoracic or lumbar spine cause paraplegia. You're going to be monitoring spinal reflexes like control of the bladder. Spinal reflexes can be absent in early spinal cord injury but could return. May develop neurogenic bladder, which is voiding is caused by skin stimulation. I'd like to add on here, if anybody is a Florida State fan, you know, Miss Dad goes to Florida State, so I'm getting my doctorate, so I'm a big fan. So last year, one of our freshman football players, I think his name is Ethan Pritchard, he was shot in the back of the head. He went to one of Florida's best rehabs, Neuro rehabs, Brooks up in Jacksonville, and he is starting to walk again. So just imagine being shot in the back of the head. That is a cervical injury, and he was in a wheelchair, but now he is showing so much improvement by walking with, I think he has like I can't even think of them, but they kind of help him walk, which is great improvement. So just because you have a spinal cord injury is not the end all be all. Medicine has improved tremendously. Now your non-surgical management of your spinal cords. Fixed skeletal traction, so it realigns the vertebrae, facilitates bone healing, and prevents further injury, keeps them in a straight line till they heal. Immobilization, especially for those cervical injuries, they must wear that C-collar, and you are not taking that off of them. Most common, you're also going to have a halo fixator. Halo fixator is the halo traction. Remember, you need the wrench and the key with them at all times. You're checking for skin breakdown. There's a picture on the next slide of that skin breakdown. So the purpose of this is to decompress the vertebrae column through hyperextending it. And then immobilization, thoracic and lumbar sacral injuries, bed rest, immobilization, and maybe a body cast. So, like I said, these are your monitoring. They're going to be swollen. There's going to have some skin breakdown. Looks terrible. A quick recap of our spinal cord injuries. So a high cervical spine injury, that is your cervical injury, C1 through C5, that equals no limbs are working, so quadriplegia. Thoracic injury, T1 through T12, means paraplegia, so just the lower limbs are not working. Injuries higher than C5 is paralysis of the respiratory muscles, or your diaphragm. So the diaphragm function is no longer working. This patient will likely need to be intubated and ventilated. Basically, the patient can't breathe on their own. C3, I've always said C3 is high likelihood of morbidity. Remember, do not move a person with a spinal injury unless their head, neck, spine have been properly supported and immobilized. Damage to the spinal column could also progress to spinal cord, causing immediate complications. So respiratory distress and your spinal shock. Remember, spinal shock happens with the injury. It peaks at 2 to 3 days. It subsides in hopefully about 7 days, and your symptoms are severe hypotension, bradycardia, hypothermia. It is vasogenic. And then your long-term complications is your autonomic dysreflexia, which is your severe hypertension. And it's because your sympathetic nervous system gets dysregulated or overstimulated. And then, of course, they're going to have disorders of mobility. So a nurse assesses a client with a spinal cord injury at level T5. The client's blood pressure is really high at 184 over 95. The client presents with a flushed face and blurred vision. After raising the head of the bed, what action would you do next? So remember, autonomic dysreflexia happens above T6. You'll have severe hypertension, flushed face, sweating, blurred vision. First thing you're going to do is raise the head of the bed. But then what else are you going to do? What causes autonomic dysreflexia? It is likely a GIGU issue, or maybe their sheets or shirt or pants are all crumpled up and overstimulating that sympathetic nervous system. So you're going to palpate the bladder for distension. We would not recommend giving a beta blocker for this patient because of the breathing. It decreases the blood pressure, but the best choice for this is more of a calcium channel blocker, an alpha blocker, not a beta blocker. So your nifedipine, your clonidine, those are good ones. Next question. A nurse is caring for a client with paraplegia who's scheduled to participate in a rehab program. The client states, I don't understand the need for rehab. The paralysis will not go away and it will not get better. How would the nurse respond? So we need an unbiased statement that is not accusatory or making the patient feel some kind of way. So if you don't want to participate in the rehab program, I will let your doctor know. If you don't want to participate, that's kind of, they're asking you a question. So that's not one that you would want. Rehab programs have helped many patients with your injury. You should give it a chance. No, we're not telling people what to do. The rehab program will teach you how to maintain the functional ability you have and prevent further disability. This doesn't hold any bias, and it's giving an actual answer to their question. Well, it's not really a question, but their statement. When new discoveries are made regarding paraplegia, people in rehab programs will benefit first. No, we're not doing that one. So the answer is C. So participation in rehab programs has many purposes, including prevention of disability, maintenance of functional ability, and restoration of function. The other responses do not meet the client's needs. And then our last question. A nurse assesses a client who's experienced a spinal cord injury at the level of T5 12 hours ago. Which assessment finding would the nurse correlate with neurogenic shock? So remember, vasogenic is your spinal shock. Neurogenic is your neurons or your nervous system. It's not communicating. The upper nervous system and the lower nervous system, motor nerve system, are not communicating anymore. So what assessment findings would we find? Well, we would probably see a low heart rate because it is a form of shock. Not so much the blood pressure. They are more hypotensive. Urine output less than 30. Absolutely. They are in shock. So they could, your body's going to try and restore some fluids because the fluid is not where it's supposed to be. And it could also cause some kidney injury. So they're not going to be peeing so well. So we have heart rate, urine output less than 30. Decreased level of consciousness. Absolutely. It is a form of shock. So they're not going to be with it. And then increased oxygen? No, it's going to be decreased oxygen. So our answer is A, C, and D. Neurogenic shock with acute spinal cord injury is going to manifest with decreased oxygen, symptomatic bradycardia, decreased level of consciousness, decreased urine output, and hypotension. And that is all for your part 1.